Podcasting from Dallas, Texas. I am Shireen, and this is the Yumlish podcast. Yumlish empowers people with chronic conditions like type 2 diabetes and heart disease to take charge of their health through diet. And this podcast is created to amplify the voices of patients, health professionals, employers, and community members who are working to reduce the risk of these chronic diseases and put your health first. Dr. Sahil Parikh shares his journey to a career in interventional cardiology at Columbia University. He sheds light on the relationship between diabetes and the risk of complications from COVID-19 and the burden of illness and death from COVID-19 being disproportionately prevalent on racial and ethnic groups. Dr. Sahil Parikh is an interventional cardiologist focused on patient care, research, and teaching around the manifestations of atherosclerosis through the circulation. He has a large outpatient and inpatient practice and performs complex procedures in a population comprised of approximately 50% diabetic patients. He's passionate about advocacy for patients with vascular disease and teaching the next generation. As an engineer, he aspires to help develop new technologies to improve care for his patients. Welcome, Dr. Parikh.
Thanks very much, Shireen. It's nice to be on with you.
Great. Dr. Parikh, I want to dive right in and first ask you what led you to a career in interventional cardiology?
It's sort of a long story, but I always was interested in the biomechanics of the body. And in fact, when I was an undergraduate, I was trying to figure out if I wanted to do orthopedics because I really liked how things in the body were mechanically connected. Pretty early on, though, in undergrad, I got really interested in the fluid flow of the human body. In fact, I took a course entitled Fluid Flow in the Human Body, and I got inspired by the engineering aspects of circulation. And it was really pretty much from my freshman year of college on that I got hooked on cardiovascular medicine and specifically in interventions to modify the circulation. And that's really a natural connection to interventional cardiology. You know, at the time, it was the early 90s, and I was interested in research in the area and devices that would modify circulation. And one of the first devices of that kind was a stent. And I was involved in some of the earliest stent research, preclinical mostly, in developing new designs of stents that could be used to open up blockages. And so, to be honest, that was really from that experience and my clinical interest that I've fast forwarded now almost 30 years, and I'm still basically interested in stents and designing of stents and drug delivery in the blood vessels and opening up blockages throughout the circulation. I've had a lot of experience, obviously in between, in learning how to be a doctor, which I don't want to underestimate, but my fundamental passions remain the same.
And so, Dr. Parikh, with that, and especially with your work that you're doing currently with COVID-19, I'd like to talk through some of that. What have you seen as the relationship between diabetes and the risk of complications from COVID-19? What does that relationship look like? And also, what do we know so far, and what needs to be further researched about this relationship?
Well, I mean, the COVID-19 experience here in New York has been really life-changing. We've, as everybody knows, been probably the epicenter here in the United States, and we've seen thousands of patients in our health system with the disorder. And so we've actually gotten a pretty up-close and personal look at this illness, which in its most severe forms is clearly a life-threatening disease. It's got some unique attributes to it. You know, we perceive COVID-19 as a virus that affects primarily the lungs, but it turns out that it has significant manifestations outside of the lungs in many of the organ systems, if not all of the organ systems of the body. Some of those are direct effects, some are indirect effects secondary to inflammation and circulatory disturbances, which is where me and my team are involved. But the virus is clearly much more virulent than we would have otherwise expected from a coronavirus, which is often associated with the common cold. specifically with respect to the patients that we're talking about, those who have atherosclerosis, it's been pretty well demonstrated both in China and now in other parts of the world that patients with cardiovascular risk factors are at high risk for developing significant complications and potentially lethal complications of COVID-19. So if one were to take, for example, our patient population at Columbia, we're an academic medical center here in Manhattan with over 700 beds, which at our peak we were occupying approximately 600 plus beds with patients with COVID-19. And if you look at the statistics, most of the patients are probably between the ages of 60 and above, although there is a significant fraction, probably 45%, that are under 60. In our patient population at our hospital, it was almost 3/4 Hispanic and 20% African American, so significant percentage of minorities. And most of the patients were overweight with BMIs greater than 30, with a significant number of patients even over 35 or 40. The prevalence of comorbidities was significant. The most common was hypertension, about 2/3, but over a third of the patients had diabetes, and about 20% had chronic cardiac diseases, and a fewer percentage had chronic kidney disease. So these are patients who are at risk for cardiovascular complications, and a big percentage of them were diabetic patients. The interesting thing was that this is really looking at as a snapshot of the patients that were in the intensive care unit. So the most seriously affected patients, over a third of them were diabetics. And these were patients in the intensive care unit. And the numbers are sobering. Over half the patients who make it to the ICU are either still in the ICU or have died. And so their mortality, we expect, is going to be around 50%. So once you get sick and get into the ICU, your chances of survival, even with an excellent medical center supporting you with all of the tools we have at our disposal, it's a high mortality. So it's a very sobering, and the data, the demographic data, were published in the Lancet by our group in pulmonary critical care. So if people want the reference, we can provide that. But I think it sort of hammers home the fact that ethnic minorities are overrepresented, it seems, relative to their population density, and more importantly, the preponderance of the data suggests that patients with cardiovascular comorbidities or risk factors, particularly diabetes, are really high risk for critical illness.
And so what is it about diabetes or even a chronic illness overall that makes that risk of complications exacerbated with COVID-19?
I mean, I think the short answer, if I'm being truthful, is that we don't really know yet. There's a number of speculated mechanisms, but those are highly theoretical. There isn't really a good understanding. I can say more broadly with respect to cardiovascular complications, it's pretty clear, like I said, that there are direct and indirect effects. The direct effects are potentially related to two specific mechanisms. One is inflammation of the heart muscle itself, a condition called myocarditis, which can result in reduction of circulatory capacity of the heart. And then there's also this pro-inflammatory state, which is almost not previously been described, where patients develop very, very intense inflammation with an immune response that winds up being injurious. And it promotes thrombosis and also organ dysfunction throughout the circulation. And there is seemingly, at least in the pre-COVID era, literature that suggests that inflammation, especially in the diabetic substrate, increases the risk of heart attack and other thrombotic events, including venous clotting. And so what we're seeing in these patients is really intense inflammation, higher than expected amounts of thrombotic complications, so clots in their blood vessels, more so in the veins than in the arteries. And so the implications for that are deep vein thromboses and potential pulmonary emboli. which are clots that go into the lung and reduce the ability for the body to get oxygen and circulate it. So I think those are serious considerations that may be related and or exacerbated in the diabetic patient.
So with that, what kind of research, what kind of retrospective research is being done with the data that's being collected right now? And then how will that help us for a possible future wave in the late fall?
Yeah, so I mean, I think that we are intensely involved in research, as you can imagine. Many thousand patients have been admitted to our health center and our sister hospitals, and frankly, all of the community of academic researchers, irrespective of what flag they fly, which institution they're from, those people as scientists are working very hard to actively investigate all of the things that we can. So, for example, some of the demographics that I've given you are from a database that's been compiled here at Columbia that's continually expanding. And every single day, we are hearing about new analyses that are being mined out of these data. And, we're looking, for example, are there correlations between specific drugs that are used, for example, patients that are previously on certain antihypertensives, oral hypoglycemics for diabetic patients, and statins for cholesterol. Are those drugs protective in any way? Are there any molecular mechanisms that one could postulate that might be impacted by those pathways? There's obviously the prospective arms of these data as well, and those prospective studies are looking at individual manipulations. For example, you've probably heard of remdesivir and other antiviral drugs that have been studied for the treatment of COVID-19. They're looking at the subgroups of those studies that have diabetic patients enriched to see if there's an enhanced effect or efficacy in that population. Or, being truthful and honest, is there less of an effect in those patients? Similarly, there's anti-inflammatory drugs, IL-6 inhibitors, and others that have been studied, and we're looking at the diabetic substrate as a serious and important subgroup to see if there's a differential effect in that population. And then, I think that we talked a little bit about blood clotting, and so I'm leading a clinical trial that's looking at different doses of blood thinners that are used for hospitalized patients that might, in fact, be protective and help reduce some of these adverse effects of COVID-19 with respect to clotting. So that trial is ongoing in our ICUs right now. It's enrolling slowly only because we don't have as many critical care patients as we did 4 weeks ago. This is the beginning of June. At the beginning of April and the end of March, really, we were at the height of the surge when patients were, literally being admitted to the ICUs in record numbers. We've fortunately come significantly down from there. But we're still seeing a steady stream of patients, and we're admitting them to the ICUs not infrequently, unfortunately. And so we're going to get answers to some of these questions, hopefully, over the course of the next several months, and have some information that can hopefully inform our practices should there be another spike of cases come the fall.
So we know that, and you mentioned this just a little bit ago, so we know that minority communities are disproportionately impacted by diabetes. So emerging data suggest a disproportionate burden of illness and even death from COVID-19 among these racial and ethnic minority groups. Why is that? What is that relationship? And then how does a socioeconomic background play a role here?
Well, I mean, I think that there's a number of mechanisms that can be speculated. However, as with everything in this illness, there's very little solid confirmed evidence. There are pockets of research that have potentially suggested mechanisms, but I would be reluctant to sort of go out on a limb and suggest that there's any known mechanism. I think clearly health status and underlying health literacy really are contributory. I can, not that anecdote would make for data, but I have a number of my own patients who live in the community around Columbia. And these patients are mostly people of color. Many are immigrants. And they frequently have access to care of the kind we can deliver. However, their overall health literacy is not very high. And it seems that For example, the concepts of social distancing are very, very difficult when you live in a joint family with multiple heads under one roof. And the younger members of the family are obviously generally essential workers, and they're out there in the community working and getting exposed. And those exposures are brought home and often affect the most vulnerable amongst us, many of whom are older, diabetic, and frequently with other comorbid illnesses, including hypertension and or frank coronary disease. And so, we're seeing that in these populations, specifically in neighborhoods like Washington Heights, where my medical center is located, that these factors may be in play. If one were to do a zip code analysis of New York, some of the most hard-hit areas are also very densely populated and are of lower socioeconomic status based on the demographic data that are available. And they include areas in the boroughs of New York, such as in Queens, and other places that have been in the lay press because of their heavy burden of illness and near or incipient collapse of the healthcare systems in those areas. Now, again, fortunately, we've come a long way since the height of the surge, and the health system has recovered. But we're still trying to better get our heads around what are the socioeconomic factors, and is it a higher prevalence of underlying comorbid illnesses such as diabetes and hypertension, which has been known for some time? Is it some other factor, or is it this, at least to me, this evident lack of health literacy that makes social distancing and preventative care easier to achieve? And admittedly, I'm sympathetic to the plight of many of these patients who are unable to stay home for economic reasons. They have to work in order to put food on the table. And that's been a calamity that we've been dealing with all over the country, as you know. But certainly in the hardest hit areas like New York, and certainly with a seroprevalence of over 20%, maybe 25%, it's not a big stretch to imagine that the folks that are the essential workers and are exposed regularly are the ones that have the highest burden of disease.
Mm-hmm. And so talking about having that interaction, going in, working, we are saying, stay at home orders for the most part have started to get lifted, if not already completely lifted in most states. But there seems to be still a sense of hesitation to visit hospitals specifically. It seems that the fear of COVID-19 virus is deterring, people who are seriously ill from visiting the hospital. And we're sort of seeing that impact and that effect there. What kind of risk does this pose to an individual? And then what would you say to sort of calm those nerves down and invite people back into the hospital?
Well, yeah, I mean, I think it's really important to recognize that during the pandemic, we've seen a dramatic reduction of people coming to the hospital with garden variety emergencies, everything from appendectomies to gallbladder attacks to heart attacks. And, it's clear that patients are suffering at home and in some cases dying at home because they're afraid to seek care. And they're particularly afraid of the hospital emergency room and or the hospital itself. But in general, they're afraid of seeking care and going to a doctor's office where they might be infected, or at least they perceive that they might be infected. They don't necessarily believe that the social controls that have been put in place and the social distancing practices implemented in the hospital will protect them. And so they're concerned. And I think in some cases that concern is founded, and in many cases that concern is unfounded. Certainly, to get to the statistics, just to, as a slice of my life as an interventional cardiologist, we are the doctors that come in when people have heart attacks and do emergency angioplasties. And we've seen a 40% reduction nationwide, irrespective of the seroprevalence of disease in the area, in people coming to the hospital for what we call acute MI or myocardial infarction angioplasty. And clearly, that number we don't think will have been attenuated by COVID-19, not by staying at home or reducing stressful activities or what have you. We think, if anything, we should be seeing a steady influx of patients with that illness, and we're just not seeing that. And I can say again from anecdote that we've had patients that have toughed it out at home and have probably lived through their heart attacks in some cases, but unfortunately in many cases died from their heart attacks at home. In New York City, FDNY has seen a fourfold increase in mortalities at home during the pandemic. And whether those are COVID-19 or mortalities from other garden variety illnesses is not clear. But to me, they're all, consequences and casualties of COVID-19, because I suspect many of those patients would have activated EMS sooner or have come to the hospital had it not been for the pandemic and their concerns about the overwhelmed infrastructure of the hospitals and or the risk of getting infected themselves. So, I would implore patients, hopefully they're listening out there, that if you feel symptoms that are troubling you, chest pains, shortness of breath, if you have infectious symptoms, the fever and cough, and other kinds of symptoms that are troubling you and are in your heart of hearts really not normal, you should seek care. And there's many ways to access care now with remote mechanisms. Telehealth has taken off, and I suspect will be here to stay and will provide us with hopefully greater access for patients who are unable to access care in traditional ways. And it doesn't have to be anything more than a phone call. And I know that's probably not easy for everybody, but even a telephone call can get you connected with a healthcare provider who can, over the phone, help triage your symptoms and give you some meaningful advice for how you should proceed. And if you're encouraged to go to seek care, please don't be afraid. While there is risk of infection that will never be zero, the risk is close to zero. We looked in our hospital data for patients who presented without COVID-19 during this pandemic and were kept on what we call COVID negative floors, and the risk of infection was essentially zero. I think there was one patient who changed from negative to positive in the hospital, and it wasn't clear if they had already been exposed in the community because there were contacts in their family that were ill. So, I think we were able to, with protective equipment, the PPE or personal protective equipment that we're offering patients and also for the providers, most importantly, we've done a very good job, even though it doesn't always sound like it. We've done a good job with protecting people from getting sick in the hospital. So again, I can't say it strongly enough. If you feel sick, please seek care and let us help you, because it would be even more tragic if we let the virus beat us by preventing us from accessing the care that's available to us.
So with that, Dr. Parikh, we're toward the end of the episode. I'd love to let our listeners impart with how they can learn more about your work and how perhaps they can connect with you after this podcast.
Yeah, certainly. I think we'd be delighted to be accessible. I think you're going to post some social media links, and you can reach us through Twitter and LinkedIn. Certainly, you can reach us at New York Presbyterian. Our direct telephone line is area code 212-305-7060, and that'll be answered by one of our receptionists. And of course, we are out there, and we have email and other data that's posted on the websites, so you can reach us in any way that you feel appropriate. I think the most important thing I always say in any of these kinds of discussions is that patients should seek care locally and talk to their doctors. Your doctor will be well versed, I'm sure, in the implications of COVID-19 for you as a patient, and will more importantly know you better. And we certainly are available to answer questions and to help provide guidance, but your doctor is your best resource, as always.
Great. So with that, Dr. Parikh, I want to thank you so much for coming on the Yumlish podcast, giving us all these insights and also sharing very valuable information and very timely for what's going on out there. Thank you.
It's my pleasure.
So
Thanks
much.
for having me.
Thank you for listening to the Yumlish podcast with Shireen. If you like our show and want to learn more, you can find information at yumlish.com. You can also leave us a review here. We will see you at the next one. And remember, your health always comes first.